Welcome to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Through expert discussions and insights, this podcast will feature information that can help physicians of all specialties address the epidemic of opioid overdoses. Free CME is available. I'm Dr. Bobby Mukkamala, board-certified otolaryngologist and a member of the American Medical Association Board of Trustees. As opioid use and the overdose crisis continue to affect adolescents and young adults in the U.S., pediatricians are increasingly involved in preventing and identifying substance use early, reducing the harms that come with it, and providing effective treatments. By building trusting relationships with both youth and families, pediatricians offer substance use guidance, support, and resources to best address concerns early on and foster healthy long-term outcomes. Joining me in this discussion is Sharon Levy, a pediatrician and board-certified addiction medicine specialist and a professor of pediatrics at Harvard Medical School. She is also the chief of the Division of Addiction Medicine at Boston Children's Hospital, the first such division in a children's hospital in the country. She is also a past chair of the American Academy of Pediatrics Committee on Substance Use and Prevention. Welcome, Dr. Levy.
Thank you for having me today.
Absolutely. Thanks for being here. And tell us more about your work and your research, if you will.
So I am the chief of the Division of Addiction Medicine at Boston Children's Hospital. This is a division that has an outpatient clinical program, a research program, and an addiction medicine fellowship training program. So our clinical program provides outpatient subspecialty substance use care to adolescents, mostly in the high school age range, and some young adults as well. We also provide support and consultation to pediatric primary care providers who need help in addressing kids with substance use in their own primary care practices. Our research portfolio is very broad-based. We've put a lot of effort into developing screening tools so that pediatricians can quickly and easily identify kids who have substance use disorder, all the way through working on a vaccine that would help prevent overdose from fentanyl exposure.
Thank you. When we consider the substances that youth used both in the 90s and the 2000s compared to today, what do we notice? Can you walk us through an overview of the pediatric landscape of drug use and how it's changed over time? And what does youth substance use look like now? And how are they accessing these substances? What are they using? What can you tell us about how it's changed?
Well, in some ways, I would say the more things change, the more they stay the same, right? So alcohol, cannabis, and nicotine or tobacco products are numbers 1, 2, and 3. I like to think of those as the big three. And ever since we've been recording data, those have been the 3 most common substances used by teens. And I don't think that will ever change. But what has changed is the actual products change and evolve, right? So a lot of folks listening may be familiar with the story of vaping, right? Vapes didn't exist before, the 2010s. And they really didn't catch the attention of young people until somewhere in the mid-2010s, like 2016, 2017. And they went from not existing to being an epidemic in just a year or two. And of course, the active ingredient in there is nicotine, just like it is in cigarettes or other tobacco products. But vaping is very different than smoking or chewing tobacco. And so although the active ingredients don't change, the products change. And the same is true of marijuana as policy has been changing and more states have been making it possible for people to legally access cannabis in one form or another. We've seen the products get stronger, more potent, and delivered in different ways. Again, through vaping is one of the most common ways. And so although the substances are the same, the risks are actually a little bit different. I should also say that after the big 3, the next most common form of substance use for teenagers is something that I think of as like pill taking. So like, for example, a young person who takes a stimulant to help concentrate or a pain pill because they have a headache. So I would say that a lot of kids don't necessarily consider this like drug use, but it's a very high risk behavior, especially these days, because for the past decade or more, the drug supply is so contaminated with fentanyl that a teen who gets a pill from a friend and thinks it's Adderall and is really just trying to buckle down and study for a big midterm exam might actually be taking fentanyl and can overdose accidentally without even knowing or without even intending to take an opioid.
Hmm. That's a very scary thought. So, as physicians, we often consider the epidemiological triangle and thinking about the various determinants that impact health. So, can you tell us a little bit about the triangle model and what this approach encompasses?
Yeah, the epidemiological triangle really helps me in thinking about who's at risk and what the risks really are. So I think one way to think about it is that, of course, not everyone exposed to an opioid will develop an opioid use disorder, right? We know that, right? So, what are the risk factors that make some people more vulnerable to others? And the epidemiological triangle is a way that we can think about that because it reminds us that risk factors really kind of come in three flavors. They can be individual risk factors, right? Things that make individuals unique, right? And it can be like genetics, it can be, the medical conditions or mental health conditions that actually do change people's risks, or they can be environmental, right? So, people who grow up in stressful environments or who are exposed to adverse childhood experiences, those who live in difficult environments in other ways are going to be more susceptible to developing a problem if they're exposed to opioids. And then finally, the third corner of the triangle is the agent itself, right? The drug itself. So we know that, there was a big class of opioids, but some forms and some specific members of the class and some ways of delivering the drugs make them really more addictive. So it's more likely that somebody who uses them in certain ways will become addicted than people who use them in others. So when we think about putting all of those risk factors together, we can get a sense of who's at risk and what can we do to modify people's risks and reduce them. Now, some of the factors, they're not going to be changeable, right? So your genetics are what they are, right? So we can't change those. But actually, they're not destiny, right? So, there are things, even in people who come from families with big histories of substance use disorders, we know that there are ways that we can protect those people, right? And when it comes to young people, I think the first thing we ought to be thinking about is sharing what's appropriate with young people and, letting them know, right, making them aware of those risks at a time when it's developmentally appropriate to do that. For most disorders, age is a risk factor that we can't change because, of course, we can never turn back time, and most diseases get more common as people get older. Here, though, with substance use disorders, that whole paradigm is actually flipped on its head. So the younger people are when they start using a substance, the more likely they are to develop a problem. So delay, right? That's the best thing that we can tell kids that, for alcohol, it's been very well studied that people who start alcohol in their early teens are about 6 times more likely to develop an alcohol use disorder than people who start in their late teens or early 20s. It's about the same for cannabis, and it's also the same for opioids and every other substance, right? And we know that as kids get older and their brains develop, their frontal cortexes is the last part of the brain to develop, is actually able to provide some protection. So delaying initiation is something that can really help. When it comes to things like adverse childhood experiences and stress, I mean, we need to be thinking about things like identifying and treating mental illness and mental health symptoms. And of course, we talked about precautions for people who we know are likely to have genetic risks. So when we talk about environmental factors, things like the social determinants of health, we're becoming more aware of these. And the more we can get kids growing up in safe neighborhoods with good schools and strong social connections and lots of helping adults in their lives, the more that we're going to be able to reduce the risk of substance use disorders. And then finally, when it comes to substances in general, drugs that are more potent, that are stronger, and those that reach the brain faster are going to be more addictive. So with the opioids, just like every other kind of drug, some types are more addictive than others. And, fentanyl is a particularly potent opioid, right? So it's, among the higher risk substances. So these are the things that we really think about when we think in the big picture of how do we do prevention or how do we think about public health.
Yeah, no, that's something to remember. Delay, delay, delay.
Exactly.
So addressing substance use with youth can be sensitive, and it's important to approach it in a way that avoids stigma and actually encourages open dialogue. So How do you typically handle screening conversations to ensure that they're non-judgmental and supportive in a way that gets young people to sort of open up and discuss things with you as opposed to withdrawing?
Yeah, that's a really great question. Well, so we've developed a number of screening tools that have been validated. In other words, they've been administered to like hundreds and hundreds of kids and then compared to diagnostic interviews to look for substance use disorders. And there are a couple of really brief screening tools that primary care providers can use in their practice with young people, and that very quickly and efficiently can identify kids with alcohol, cannabis, and nicotine use disorders, right? It's actually pretty remarkable because in the two tools that are most commonly used, there's just one single question about each of those three substances. And with that one question, we can really pick out kids who are more likely to have a substance use disorder. So some of the ways that we destigmatize is that we do universal screening. We don't try and assess ahead of time who's more likely to have a substance use disorder, because if we do that, we can miss some kids who do have a substance use disorder. And also we're introducing stigma into making that kind of decision. Another thing that we can do to improve the experience of screening is that we can have kids do this themselves, right? So it turns out that kids really prefer to answer questions themselves, either on paper, but these days I think more and more on an iPad. I think best practice for, routine healthcare visits for young people is to send the questions out ahead of time on the portal. I think we're all getting used to the idea that before we have a doctor's visit, we're going to have to sit down and go through a bunch of screening tools to look for signs of depression, signs of anxiety. And I would just include the substance use disorder screens right in there and have them fill them all out. So all of that's done really in the privacy of a young person's home without them needing to answer face-to-face a question, to an adult, right? So they can answer privately and confidentially, even though they're aware, of course, that the information is going to go back to their physician.
Yeah, that seems like a really nice way to get them to open up and to do it in a comfortable setting for them, as opposed to sometimes the intimidating sort of sterile condition of an office room.
Right. That's true. Now, I will say, and I've worked with teenagers for a really long time, that I know that just because we push out some screening tools on a portal, it really doesn't mean that every kid is going to sit down and work their way through them before their visit. So if they don't, we always need to have a backup, right? So the practice that I take my kids to, they just give you an iPad while you're sitting in the room. Again, it's probably better if you can do it in the privacy of your own bedroom. But if they haven't done it, we need to make sure that there's an opportunity to find some other time. So we at least collect the information. And, this screening, it's really important that it happen in primary care, because what we know about interventions, like when we're talking to kids, we know that the more we can tailor them, the more salient they're going to be, the more effective they're going to be. One example is that my group developed an intervention to help reduce alcohol use in kids with chronic medical conditions like diabetes or inflammatory bowel disease, right? And so for these kids, they're actually more vulnerable, right? We did a lot of work with this group and we heard stories over and over again. Things like, kids choosing not to take their medications because they were worried about an interaction between alcohol and their chronic medication. So on a night they knew they were going to go to a party and they were going to drink, they would just skip their medication. I mean, maybe that sounds reasonable. Certainly to a 16-year-old brain, that might sound reasonable, but it's really a risk factor for inducing a flare. And what the kids told us is that they had heard from their doctors that, alcohol is not healthy for them, it's bad for them, but that's really all they ever got. They never got enough information to feel like they knew why. And what they told us is like, hey, we've been living with these conditions for a long time. We know something about it. Give us a little bit more information. Let us really sink our teeth into it and understand why. And so we developed a very brief electronic intervention. So it's basically slides that kids could look on an iPad. And it talked about a lot of the emotional content that we had heard from them when we were doing the initial work. And then it inserted some very specific medical content in the middle. And then we did a randomized control trial. So we recruited 500 kids with one of the chronic medical conditions of interest. And half of them saw the intervention. The other half didn't get an intervention. They did this in a waiting room while they were waiting for an appointment. And 6 months later, we saw that there was a little bit less alcohol initiation in the group that had the intervention. And then at 12 months, we saw this really remarkable finding that the kids in the intervention group, who were the heaviest drinkers at baseline, had actually decreased their drinking, while the kids who were the heaviest drinkers in the control group, their trajectory continued to go right on up. So those two lines crossed, really establishing that the intervention was very effective. And it's that knowledge of the person in front of you that, primary care doctors, especially pediatricians, family medicine practitioners who have known kids their whole lives, they know something about them. So they can really personalize and tailor that information. And I think that that's a nice example of how effective that can really be.
For sure. So, what would you say to our listeners to encourage them, to motivate them to help meet the needs of youth who may be at risk of an overdose? Like, how can they make a difference? What would you say to them?
One of the things that we learned in the big screening study is that, we were effectively picking out kids with alcohol, cannabis, and nicotine use disorders. And what we know is that use of the big three almost always precedes use of other substances. So really getting in there and talking to them about early substance use is an important part of what we call secondary prevention. That's kids who've already started using substances, but we really want to prevent opioid use or risk of opioid exposure. Talking to that group is really effective. Another thing that we found out, though, is that depending on which tool we used, some of the tools, 8% of kids told us that they had used some sort of pill in the past year. And of those, about half were also using alcohol, cannabis, or nicotine, and the other half weren't. So there was a group of kids who said that they were using pills even though they weren't using other substances. Now, a lot of these kids may have actually been what we call false negatives, right? What they meant to be telling us is that they had used a Tylenol pill appropriately, which we wouldn't consider drug use, of course, but they didn't really understand the question. But, I think you could really make the argument that that's an important young person to have a conversation with, because if you are speaking with an adolescent who's not really distinguishing between Tylenol and Percocet, it's a really good opportunity to explain the difference and to talk to them about safe use and, the difference between over-the-counter medications, which can be used, right, safely by people at home, even without the advice of the doctor, as long as they're used by the directions on the bottle, versus use of somebody else's prescription or prescription medication that wasn't prescribed to you, right? So straightening that out for them and really helping them understand that difference seems like a really important activity and something that we can really do in primary care and make sure that kids, even young kids, are understanding those differences. And then, frankly, even when it comes to over-the-counter medications, I would encourage parents to supervise even Tylenol and ibuprofen medication while their kids are teenagers. It seems like just a good check-in before any child takes a pill to just check in with a trusted adult.
Mm-hmm. And building on that, I imagine, family plays a huge role in these conversations. So what resources do you find yourself sharing with families of your patients when they have concerns about drug use?
So I really encourage parents to give really clear messages to their kids discouraging drug use. And the way that I usually phrase it, or the way that I suggest parents phrase it, is like, look, you don't have my permission to use substances. I can't tell you how many times a family comes in, I speak to the adolescent and I ask them, so what do your parents think about you, going to these parties and drinking? And they'll say something like, well, my parents think, that maybe they don't like it, but they think that as long as I'm safe about it, it's fine. And then I speak to the parent, a week later, and they say, that's not exactly what they had in mind, right? What they meant to say is, I don't want you to do this. But somehow the message wasn't getting across or getting across clearly, right? So, parents need to use language as clearly as possible. I encourage parents, if your teenager says, hey, can I go out with my friends tonight? There's a perfect opportunity to say, sure, as long as you can confirm to me that you will not use alcohol, cannabis, nicotine, other substances, so that they're having those conversations, that they're having them clearly. And on another note, I would encourage primary care providers to be talking to families about naloxone. So, I think there's this tacit assumption that people who die of an opioid overdose have opioid use disorder, but that's not always true. Certainly for adolescents, that's often not true. In fact, we know about 2/3 of the young people who die of an opioid overdose were not known to be opioid users. So this is coming up completely as a surprise. And over half of the lethal overdoses are actually happening at home, often with a parent or another adult in the house. So it's really important that we get naloxone out to everybody and show folks how to use it. In our clinic, which is a substance use disorders program, we send everybody home with a prescription for naloxone or instructions on how and where they can get it and, a video on how to use it. I think that's really, really important because it's life-saving and it's the kind of thing that you just need to have in the right place in the right time. So giving out lots of it and destigmatizing it and telling everybody, look, if your kid has a peanut allergy, you'll have an EpiPen in the house. And if your kid's a teenager, you should have naloxone at home.
Yeah, those are really impactful resources for patients, it seems. And so a reminder to our listeners that if you'd like to hear more on prevention approaches, you can check out one of our previous podcasts called Opioid Use, a Prevention Approach, that's available on the AMA EdHub. So, Dr. Levy, can you walk us through pharmacotherapy treatment options for youth that have an opioid use disorder? I mean, are there safety and efficacy considerations that come into play when prescribing for adolescents?
Yeah, so adolescents are really underserved when it comes to pharmacotherapy, particularly for opioid use disorders. So buprenorphine has an indication for ages 16 and up with opioid use disorder. We certainly use naltrexone. We use buprenorphine for younger adolescents when we make a diagnosis of an opioid use disorder, and we use naltrexone too. Pediatricians are used to using medications off label. We understand that the studies are often not done in children or younger people. So methadone is less commonly used in younger people because you have to get methadone from a specialty program. And most of those programs, for various reasons, can't admit adolescents to the program. So that's a less common option for this age group, although I know that there's been some interest in Congress and maybe changing those laws and some advocacy by the AMA. So I thank the folks who are doing that work. And, maybe that will change over time to give us more options. I think that when it comes to using these medications, they're largely used in the same way as they are with adults, although there are some differences that we need to pay attention to. So I think in many ways, one of the biggest differences is just simply that we will see kids with shorter histories of opioid use, usually when they present, just by the fact that they're young people like coming to your attention. You're unlikely to see a 16-year-old who has a 10-year history of opioid use, right? And so often when kids come in, they have very short histories, just a couple of months. And when you're looking at somebody who's really that early in the course, I think it can be really challenging to know what the right decision is in terms of medication. So if somebody's coming in, they're very early in their course, our recommendation is often to offer naltrexone as first line, particularly if they've been able to stop, which, often they are before they even get in, and with very close observation and usually with drug testing as well to see how they do, but really with frequent visits and to see if they're craving and to adjust their medications as necessary. The reason we do that for people who are, very early in a course is because buprenorphine is, of course, also an opioid. And, we try not to expose young people's brains to opioids. So the extent that we can avoid that, we try to. On the other hand, somebody who's got an opioid use disorder and is having cravings and is finding it challenging to remain abstinent, we will certainly move quickly to buprenorphine to see if that will help. And, I would say there's not enough empiric data to know, what dose should we start with or how long should people be on these medications, especially younger people who are on them. So, there's a lot of partnering with young people and their families if they're involved, which hopefully they are, to make those decisions. It's our clinical practice in general to start with a lower dose. Really, when we're starting buprenorphine, we try and start with just enough to manage withdrawal symptoms so that we don't send somebody home who's not feeling well. And then we'll see them frequently and we'll titrate as needed to try and suppress cravings as best we can. I know different clinics have different practices. And in the adult world, I think people will often start with bigger doses just to really get a big loading dose on there and then stabilize patients as quickly as possible. Sometimes we do that, particularly for the young adults or the people who have longer histories. But for very, very young teens who are being started on buprenorphine, again, we want to keep them on the lowest dose that's going to stabilize them. And so we find that the easiest way to do that is to start low, make sure kids are feeling well, try and get as much structure in place for them so that they're watched, see them frequently, and then titrate up to try and address cravings as best we possibly can.
Thank you for pointing out the advocacy that we're both doing with our organizations to improve access to methadone for people with substance use disorder. So that standard, that double standard that often exists between buprenorphine treatment and methadone starts to disappear. So what behavioral health interventions do you recommend to patients that would like more support in dealing with their substance use disorder on top of the pharmacotherapy that we've just talked about?
Well, as with adults, behavioral health support is so important. I think of treatment for opioid use disorders really as like a three-legged stool, right? So there's the medical component, and that includes medications. And then there's, emotional support. And that is that lots of patients with opioid use disorder have a lot to work through. Depression and anxiety and other mental health symptoms are very common. Trauma is extremely common. And making sure they have a counselor who can support them, who can help them work through that. That person is often going to be somebody who can teach them how to manage cravings, how to manage, these different experiences that they're having. And so, getting that lined up, is really going to help people. In my clinical experience, it really helps people get into a strong recovery. And then there's this third piece, which is the behavioral support. And for adults, I think that it will often look like peers, right? So that's the person who's going to help you learn to re-navigate your community safely, right? Because if you've spent a lot of time in your community, you might be triggered in different places and really need to relearn different patterns for yourself to stay in a strong recovery. For young people, we don't usually match a 15-year-old up with another 15-year-old. So sometimes some programs will have older peers. We usually use parents in that role, so it's not exactly the same experience, but we do a lot of teaching of parents to do some behavioral support for their young people. And it's often things that are really simple, but really, really important. So, for example, the benefit of, just simple praise. So kids who have opioid use disorders, typically they've heard a lot of negative comments from the adults around them. And to flip that on its head and to have parents just notice and pay attention when their kids, even just for trying, right? You made it to your appointment on time. That's terrific. You got to school today. Even those really little things, and teaching them how to celebrate the little milestones, while at the same time, setting appropriate limits and helping their kids learn to negotiate that. That is largely the behavioral health piece. We also use a lot of groups for young people, which I think can be very helpful. It is more peer-to-peer support, and that mutual accountability piece as young people are going through this is often very helpful and, again, gets them into a stable recovery. Now, of course, some kids will just need more support than is reasonable to provide in an outpatient program or in home care. But I think too quickly, people assume that kids with opioid use disorders will need to go to a residential treatment program. We've treated hundreds or more kids over the years very safely and effectively in an outpatient program. So that's something else that I want to put out there. There's one more thing I want to say about treatment, and that is that in my experience, we only run an outpatient program. And in my experience, we always want kids to be in the least restrictive setting possible. I think that whenever we can treat kids in an outpatient program, really that's what we should be doing.
Yeah, thank you for that. It's really been an insightful discussion. So what takeaway points would you like our listeners to remember the most?
In terms of summarizing, I think that my big takeaways are that prevention is really the name of the game, especially when it comes to young people. As with any other condition, we're going to do so much better by preventing addiction than trying to treat it. I like to say, as a pediatric addiction medicine specialist, I really am trying to put my adult addiction medicine colleagues out of business. I think that if we could get to everybody in those teenage and young adult years and delay onset, bend those trajectories, we could really, eliminate the problem of addiction for the entire population. So it's all about prevention. It's paying attention early on. It's talking to kids about substance use. And, it's really about creating teams and networks for kids so that they have trusted adults who are giving them the same message and who are providing support for them in their communities, be that at home or at school. And that, to a large extent, I see primary care clinicians as leading that charge, as really the ones who can provide the education both to parents and patients so that we all get on the same page.
Absolutely. Very good point. Well, thank you so much for joining us today, Dr. Levy. Very much appreciate you being here.
Oh, it's my pleasure. Thank you for having me.
Thank you for listening to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Make sure you tune into other episodes of this series to learn more about opioid use disorder, and harm reduction. Visit the Resources tab to learn more. Complete the quiz to earn CME. This content is for educational and informational purposes only and does not constitute medical or legal advice. The viewpoints expressed in this podcast are those of the participants and do not reflect the views and policies of the AMA unless otherwise indicated.